Good morning, respected dignitaries, teachers and dear colleagues. Today we are presenting 34th PGCR on the topic of screening of common cancers. I would like to thank Dr. Sharma sir for giving us this opportunity. I am Dr. Pranjjal from the Department of Medical Oncology. We will be covering this seminar on these topics. I will be covering the cancer burden globally and in India. So cancer, often called the emperor of all maladies, the king of all terror, a phrase popularized by Dr. Siddhartha Mukherjee, who is US-based oncologist, in his book, The Emperor of All Maladies. This title reflects how cancer has been feared throughout the history due to its unpredictable behavior and ability to spread and high mortality. The symbol of crab here represents how cancer tends to invade the surrounding tissue and extend its claws into different parts of the body. Metastasis is a unique property of cancer that leads to its fatal outcome. Now, to truly understand the impact of this emperor, let us see the global trends. Global incidence of cancer was around 20 million in 2022 as per 2022 Global data, meaning 1 in 5 individuals will develop cancer in their lifetime. And looking at the mortality, around 50% died in the year 2022. Looking at the most common cancer, lung cancer leads, followed by breast, colorectal contributing to around 1/3 of the total cancer cases. Similarly, for cancer-related deaths, lung remains the leading cause, followed by colorectal and liver. Interesting point to note here is that breast cancer, which is one of the most commonly diagnosed cancer, is not among the top 3 causes of cancer-related mortality, which highlights the success of early detection and advance in the multimodal treatment. Now shifting focus to India, the cancer burden significantly remained high as per Global 2022 data. In 2022, India reported around 14 lakh new cases, ranking 3rd globally in terms of incidence, and out of around 60% patient died, India ranked 2nd globally in terms of cancer-related mortality, highlighting the higher case fatality rate. Looking at the most common cancer in India, breast cancer accounts for 40% among females, followed by lip and oral cavity mainly in males, followed by the cervical cancer, reflecting the impact of tobacco use, unhygienic conditions and inadequate screening practices. When we look at the cancer-related death, lip and oral cavity are the leading cause, followed by lung and breast. Unlike global trends, oral cavity cancer majorly occurs in low and middle income countries. It ranks very high in both incidence and mortality in India, clearly pointing towards the public health burden of tobacco consumption. A critical point to note is that around 1,300 cases die every day in India because of these cancers. For addressing this, screening is the main modality that we can use in asymptomatic individuals to diagnose the neoplastic lesions. The importance of screening lies in 2 important aspects. First, it helps in reducing the overall burden by identifying the disease at the earliest in its more treatable stage. And second, the more important, screening allows us to detect the precancerous lesion and early stage cancer before it progresses to the advanced stage. It is particularly holding true for breast, cervical cancer and oral cancers. Now here we can see how cancer develops over time and how screening can help us. Initially, we start off with the normal cell where nothing abnormal is detected and normal screening can be continued. Over time, with accumulation of mutation, the precancerous lesion develops, like erythroplakia and leukoplakia, and at this stage, screening is very useful because at this stage, we can offer complete treatment to the patient and prevents its development into the cancer. If disease further progresses, it becomes early stage cancer. The tumor is still localized and detecting at this stage helps us in giving the appropriate treatment. As the disease further advances into stage 2 and stage 3 into the locally advanced disease, now treatment is still possible, but it becomes more complex and outcomes are comparatively unfavorable. Finally, coming to stage 4, when the disease becomes metastasis, that it goes to the other tissues, treatment is still possible, but now we can offer the palliative treatment to the patient and just in aiming to prolonging the life. So this diagram clearly highlights that earlier the detection, better the prognosis we can offer to the patient. In the Western population, the lesions are usually picked up in the early stage, in the precancerous lesion and stage 1 because of the good screening practices. But in our country, we usually diagnose patient in stage 3 and stage 4, leading to poor mortality and morbidity. Now focusing on the most common cancer, the first most common cancer being breast cancer. In breast cancer, early detection largely depends on recognizing the clinical warning signs like painless hard lump, nipple changes like retraction, nipple discharge usually spontaneous or bloody, skin changes like dimpling, puckering, pure orange appearance, recent change in the shape and size of the breast or painless hard lump. Coming to the second most common cancer in India, cervical cancer, which is mainly because of human papilloma virus in 99% case. In India, the burden is very significant and around 1.2 lakh patients being diagnosed every year and almost half of them die. And this cancer can be prevented with good screening practices and vaccination. Now in this slide we can see the cervical cancer begins with HPV infection usually after commencement of sexual activity, and most infections around 90% regress by itself, but if they progress into the precancerous lesion, for the accumulation of the mutation, it advances to invasive cancer around 30 years and beyond, and may later progress to advanced cancer. So the key point to here note is that it gives us a long window of opportunity to address the precancerous lesion and the early stage cancer. Now coming to the third most important cancer, which is preventable, head and neck cancer, which contributes to significant burden in India, accounting for 25 to 30% of all cancer. Every year around 1 lakh new cases are being diagnosed and 50% dies. India has a high burden globally, and oral cancer constitute majority and easily detectable by visual examination. Nearly 80 to 90% of head and neck cancers are tobacco related, either smokeless or smoked. Now coming to colorectal cancer. In case of colorectal cancer, we can offer screening to the patient by dividing them into average risk category and high risk category. Colorectal cancer screening is widely practiced in Western world, and we have many diagnostic tests available with us. Average risk category includes who has no history of colorectal cancer or adenomatous polyp, no family history of colorectal cancer, no history of inflammatory bowel disease, or no history of any hereditary disease. While high risk are the individuals who have the history of following things. The various screening tests available with us in case of colorectal cancer are colonoscopy, flexible sigmoidoscopy, CT-based test is CT colonography, blood-based test including ctDNA test, and various fecal stool tests are also available, like fecal immunohistochemistry, second generation multi-target stool DNA test, and multi-target stool RNA test. Here the colonoscopy remains the gold standard test and is done every 10 years. Now coming to screening in lung cancer. Lung cancer screening is done in high risk individuals with age of more than 50 years, with more than 20 5-year history of cigarette smoking or more than 20-year history of cigarette smoking. We go for low dose CT scan. Now I would like to invite Dr. Parul from the Department of Community Medicine to take the screening practices forward.
Excuse me, have you looked into the state-wise distribution of the cancers and the relative cancer detection agencies in the various states? Because you give a general overview of the Indian pattern, but state-wise pattern, have you got any kind of data?
Yes, sir. Mainly the oral and head and neck cancers are mainly more common in South Indian population, and mainly the screening practices are also from the South Indian population. Various guidelines we have from South India, like one Kerala based strategy they have given for the early detection of oral cancers.
So maybe I can highlight on that. Everybody is aware that health is in our country a state subject. So the government at the center may pass a decree or a law or a recommendation, but the states are not mandated to follow that. So we have a national cancer screening program, national cancer registry, national cancer preventive program at the national level. but implementation in the states is varied and different. With regards to epidemiology, the northeastern states, Manipur, those seven sisters, Assam and beyond, they have the highest incidence of cancer, and the main reason for that is excessive use of tobacco. Certain cancers are more common in the northern states. Most common example is the gallbladder cancer. Certain cancers are much more common in the southern states. Like, for example, stomach cancer in the southern states is the number one cancer. So there are regional differences in our country itself, not only country to country, not only low middle income countries versus Europe and US, but in our country also there are regional differences, and that is what highlights the environmental impact of carcinogenesis. In addition to the genetic mutation, there is a major environmental impact to carcinogenesis.
There's a follow-up question to that is whether the kind of genetic markers have been plotted, because there's known association, as you also stated. Has that been marked out in our Indian population, because certain cancers have got same? So any communities, anything which have been marked out for specific cancers?
For the information of the residents, there are two types of cancer registries in the country. One is a hospital-based cancer registry, and the other is the community-based or the population-based registry. The disadvantage of having a hospital-based registry is that supposing you have very good services for head and neck cancer, head and neck cancers will come here. So that is a sort of a biased registry. The other one is a population-based registry where all the pathology centers, all the hospitals, and a population-specified population is taken. So there are about 30 odd registries, including population and hospital-based, which annually publish their data in the ICMR. And there was a cancer atlas project of the country where all the different states presented their cancer data. So as far as that is concerned, and that showed, like Dr. Hemant said, in the eastern part, very high head and neck. In the northern part, like Kashmir, a lot of esophagus is there because they have very hot tea and keva, right? So that leads to problems of CSO. So various states, and one statement which I don't agree with you, South India has less amount of head and neck cancers. Why? Because tobacco chewing is not so common there, right? Residents coming from South, they have never seen commandos or these like we see here. Here, the tobacco, eating, chewing, this is too much. And as far as this is concerned, I think we'll just stick to the cancer screening and then go.
And I think just to add to that, there are certain registries which are mandatory with the ICMR, and that's what forms the basis for the certain national programs. I think the HPV was based upon that particular data which came in from the ICMR guidelines for implementation at the national level.
And I think just to add to that, happy to tell you that we have a MOU, our institution, with the National Cancer Registry Project. We have 3 or 4 data entry operators employed through them, and on a monthly basis we are providing them our cancer data, and they are giving us 8 lakh rupees a year, the National Cancer Registry Project.
I think further to this, one is we have to add electronic health record system. So that will lead to very good sort of awareness.
Thank you, Dr. Pranjjal. Good morning, respected chairperson, sir, respected teachers, and my dear colleagues. Now, I will continue with the cancer screening at community level. As Dr. Pranjjal has already given us an overview of the burden of cancer, the next important aspect is how much of this burden is preventable. Around 40% of the cancer cases are preventable. This is where primordial prevention, that is the first level of prevention, plays a key role by preventing the development of risk factors by lifestyle changes. Risk factors are broadly classified into two groups, modifiable and non-modifiable risk factors. So let's talk about modifiable risk factors. Firstly, tobacco, taken in any form, smoked and smokeless, is one of the most important preventable risk factor for cancer, accounting for nearly 30% of the cancer mortality worldwide. It is strongly associated with head and neck cancers most commonly, then laryngeal, esophageal, lung, bladder cancers. Chronic and prolonged alcohol use increased risk of liver cirrhosis and hepatocellular carcinoma, along with the pancreatic and other gastrointestinal cancers. People consuming a diet including packaged food, processed food, red meat, high fat contributes to colorectal and other gastrointestinal cancers. Infections contribute to 20% of the cancer cases worldwide, especially human papilloma virus, hepatitis B and C virus, Epstein-Barr virus, and H. pylori infection. Radiation exposure like UV rays and non-ionizing radiation also increases risk of cancer, with the classic incident of Hiroshima and Nagasaki case, where population is still showing increased risk of leukemias and other cancers. Air pollution is an important contributor, especially for lung cancers in metropolitan cities. Physical inactivity and obesity also increases risk of breast and endometrial cancers. Non-modifiable risk factors include genetic factors like BRCA1 and 2 gene mutation, which increases risk of breast, ovary, and prostate cancers. Age is a major determinant, with most cancer occurring in elder population, although some of the cancer shows bimodal distribution. Gender also influences cancer pattern, like prostate cancer in males and cervical and ovary cancer in females. Cancer prevention requires a comprehensive approach across all levels of prevention, which, as we have already discussed about primordial level of prevention, which focuses on preventing the emergence of risk factors. Now we move on to primary prevention. It aims to prevent the occurrence of cancer by controlling established risk factors like control of tobacco and alcohol use, diet, physical activity, limiting radiation and occupational exposures, reducing environmental pollution, and control of infections by vaccine programs initiated by Government of India. Also, cancer education plays a key role in increasing awareness and encouraging healthy behaviors. Coming on to secondary prevention, it focuses on early detection and treatment through screening programs, which is supported by cancer registries, and timely management to improve the outcomes. These are the warning signs of cancer, which can be studied by the use of mnemonic caution. C stands for change in bowel and bladder movement, lesion that does not heal, unusual bleeding or discharge from any part of the body, thickening or lump present in the breast or elsewhere, indigestion or difficulty in swallowing, obvious changes in size, shape or color of a wart or mole, nagging cough or persistent hoarseness. The Government of India has operationalized cancer screening under the National Program for Prevention and Control of Non-Communicable Diseases, in which cancer is the major burden. It was launched in 2010, including the population 30 years and above. The primary aim of this program is to reduce premature mortality from non-communicable diseases. It mainly emphasizes on early diagnosis and screening of the disease, and decentralizing the initial management at community level healthcare system. The main objectives are prevention and control through the behavior and lifestyle changes, early diagnosis and treatment of the cancer, capacity building, establish and develop facilities for the palliative care and rehabilitation, and strengthening the surveillance system to monitor morbidity, mortality and risk factors. Thus, this program adopts a comprehensive continuum of care approach, integrating incidence prevention, screening, diagnosis, treatment, and follow-up, which is essential for effectively addressing the growing burden of NCDs in India. There are three common cancers in India: breast, cervical, and head and neck cancers, which will be subsequently taken up by the follow residents. Now, I would like to call Dr. Akshit for breast cancer and radiology.
Thank you, Dr. Parul. A very good morning, respected chairman. A very good morning, respected chairman, sir, teachers, seniors, and my dear colleagues. Now, I would like to discuss the role of radiology in cancer screening. Radiology plays a central role in screening of breast cancer, enabling early detection and precise multidisciplinary management. For the purpose of cancer screening, the American College of Radiology has divided women into various risk categories based on the risk assessment. Average risk women are those who have no other risk factors and are above the age of 40 years. Intermediate risk women are those who have personal or family history of breast cancer but no BRCA mutation or have dense breasts on mammogram. Higher risk women have personal or family history of breast cancer with BRCA1 or BRCA2 mutation, exposure of chest to ionizing radiation between 10 to 30 years of age, or patients diagnosed with certain genetic syndromes. ACR has given guidelines for screening of women based on different risk categories. Average risk women should undergo annual mammography starting at 40 years of age with targeted ultrasound if required. Intermediate and high risk women should undergo annual mammography at an earlier age. In high risk women, ultrasound can be done as early as 20 years with annual MRI scans starting at 25 years of age. This is a quick review of the differences in guidelines between American and various European societies. The key highlight is that mammography remains the primary modality for screening across all societies with or without digital breast tomosynthesis. Also, in high-risk patients, MRI is indicated in all women above 25 years of age. ICMR recommendations. ICMR stresses upon self-breast examination after 25 years of age. Population-based screening is recommended for women above 30 years of age, primarily using clinical breast examination by trained healthcare workers. It is done once every 2 years. Mammography is not used for mass screening due to cost effectiveness and resource constraints. Mammography remains the first line screening modality with good sensitivity and excellent specificity. It is indicated in all women of screening age group and high risk women. Although there are no contraindications of mammography, it is avoided in certain cases like pregnancy, severe breast pain, recent breast surgery, etc. In mammography, two standard views are taken, mediolateral oblique view and craniocaudal view. Additional views may be taken depending upon lesion conspicuity and characterization. Here we have the standard views of mammography, the right craniocaudal view, the left craniocaudal view, the right mediolateral oblique view, and the left mediolateral oblique view. Since screening mammography is done annually, there is a concern amongst the people regarding the radiation exposure. However, the radiation exposure in annual mammography is well within the FDA-mandated safe limits. Digital breast tomosynthesis. It involves multiple projections acquired across an arc that are reconstructed into a series of stacked images giving 3D information. Its advantages include increased screening sensitivity, better lesion localization, improved cancer detection, and lower recall rates. Radiation dose is similar to conventional mammography with advanced reconstruction algorithms. Here we have in these images we can see the 2D mammogram images of craniocaudal and MLO view, in which we can see subtle architectural distortion, where seen on DBT shows a mass, and on magnification we see mass with speculated margins. Breast ultrasound is the second line of imaging for screening of breast with good sensitivity and specificity. There is no radiation exposure, hence it is absolutely safe in pregnancy and lactating women. There is improved cancer detection when combined with mammography. It is the preferred modality for guided biopsy. It is indicated in women with dense breasts where mammography sensitivity is reduced, in high-risk women for adjunct screening, in young women to avoid radiation exposure, and in pregnant and lactating women. There are absolutely no contraindications of ultrasound. Breast MRI. It is the most sensitive modality for detecting breast cancer with excellent sensitivity and specificity. It is done in prone position only with dedicated breast coils. Dynamic contrast enhanced MRI is the standard protocol which is followed. Contrast enhanced MRI should be done between 7 to 14 days of menstrual cycle. Pertaining to screening, annual MRI is indicated in only two scenarios: annual screening in high-risk patients and detection of contralateral occult cancer. MRI is contraindicated in patients with non-MRI compatible pacemakers, certain ferromagnetic implants, gadolinium allergy, and severe claustrophobia. Relative contraindications include renal failure and inability to lie prone. BARADS, or Breast Imaging Reporting and Data System, is the most clinically important standardized reporting system for classifying breast lesions. It helps in guiding further evaluation, follow-up, and necessary management. BARADS stage 4 and stage 5 are suspicious for malignancy, with likelihood of cancer ranging anywhere between 2 to 95% in category 4 and more than 95% in category 5, warranting a tissue biopsy. These are the cases from our mobile screening van. Here, a 60-year-old woman came for screening, showing high-density irregular mass with spiculated margins in the central quadrant of the right breast. The lesion had suspicious morphology and was given BARADS 4B. This is the mammography report for the same, which was made adhering to the standard lexicon. Subsequently, a contrast-enhanced MRI of the same patient was done, which shows a heterogeneously enhancing spiculated mass, which confirmed the suspicious nature of the lesion. This is another case. A 42-year-old asymptomatic lady came for screening, showing high-density irregular masses with spiculated margins with adjacent linear and linear branching calcifications seen in the upper outer and central quadrant of the left breast. These findings are highly suspicious for malignancy and was given BARADS 5. This is the mammography report for the same. Screening of colorectal cancers. In addition to breast cancer, radiology also plays a role in screening for colorectal cancer. Colonoscopy has been traditionally the investigation of choice for screening. However, with recent advances, CT sonography is also used for screening. In average risk individuals who have no significant family history, CT sonography is used every 5 years starting at 45 years of age, and colonoscopy is done once every 10 years. In high-risk individuals, colonoscopy with adjunct CT sonography is done every 5 years starting at 40 years of age. Here we compare the findings of CT sonography with that of optical colonoscopy. Here with 3D reconstruction, we can see a polyp arising from the wall of the large hole. When compared with the findings of optical colonoscopy, show similar results, showing the accuracy of CT sonography to that of optical colonoscopy. Screening of lung cancer. Radiology also plays a role in screening of lung cancer with increasing number of cases nowadays. Average risk individuals who have no history of smoking or occupational exposure require no routine screening, while high risk individuals should undergo annual low-dose CT chest. Here we have a standard HRCT chest in which the radiation exposure is 5 to 7 millisieverts. When compared with ultra-low-dose HRCT, the radiation exposure is 1 to 1.5 millisieverts. These images demonstrate the ability of ultra-low-dose CT to adequately maintain the diagnostic accuracy in identifying and characterizing pulmonary nodules. Now I would like to call upon Dr. Aastha from the...
So what are the recommendations in our country? Where is the first mammography to be held? What is the frequency at which it is to be repeated? And till what age? That is my first question. The second question was, I think your second or third slide talked about BRCA testing.
Yes.
Now, are you recommending BRCA testing before the mammography is done?
Actually, sir, first of all, to answer your first question, in our country, the ICMR guidelines, they mostly stress upon self-breast examination and clinical breast examination in patients above 30 years of age. Mammography is recommended, however, it is not used for mass screening in our country.
That is exactly what I want to know. What is the recommendation for mammography? Because BSc
as well as CV are highly subjective, especially.
Yes, definitely, sir. That is very true.
Also, recommendations of mammography are country, if at all there are. That is my first.
So I would like to add to that. Good morning. So as Dr. Akshit said, so there are no screening guidelines per se because of resource constraint. But whatever breast imaging societies are there, they like.
Yourself. Everybody should know who you are. Just introduce yourself.
I'm Dr. Anandita. I'm assistant professor in Department of Radiology. And so pertaining to the question, the first is there are no nationalized screening program as such. It is of course as sir said before, it is quite state based and institution based. Now coming to what are the recommendations of the breast imaging societies per se. So we have our Indian Breast Imaging Society and they are mostly adhering to the ACR or the American College of Radiology. Now there are two reasons for that. One is the ACR philosophy. So they are based on the philosophy of doing an opportunistic screening. That means a patient will come to the hospital if she is of the screening age group. We'll ask her to get a screening mammogram done. Second philosophy is that the Americans believe that it is better to not miss a cancer rather than overdiagnosing. And these are the two philosophies which in our Indian setup is more easy to develop, to acquire. So that is why BISI recommendations are like Breast Imaging Society of India recommendations align with that of ACR. If we are comparing it with the European Society, then they are registry based. So once a woman turns a certain age or screening age group, they will get an alert on their phones that they need to come for screening. They are given, they will get an alert every 2 years to come back for a recall, and that is not possible in countries like ours. So that is one reason why we try to stick to an opportunistic kind of screening.
So, what is dynamic MRI breast examination?
So dynamic contrast enhanced MRI is done in certain cases for patients with in high risk category group. It is done basically for identifying lesions which are highly suspicious, seen on mammography, confirmed on ultrasound, and further to see the extent of the how much is the spread and myths. So it is done with using contrast agents, gadolinium contrast agents. Basically, the sensitivity of dynamic contrast enhanced MRI is anywhere between 90 to 96%. It is highly useful in diagnosing occult cancers. Now I'd like to call upon Dr. Aastha from the Department of Gynaecology to tell us more about cervical cancer screening.
Thank you, Dr. Akshit. Thank you, Dr. Akshit. Good morning, respected chairperson, sir, dear teachers, and my respected my colleagues. Today, I'll be talking about cervical cancer screening and HPV vaccination. Moving on, why screening of cancer cervix is effective. Cervical cancer, it starts with infection by the human papilloma virus, where immune system clears the infection on its own. Now, since infection with human papilloma virus leads to precancerous lesions over 10 to 20 years, further causing invasive cancer, here it has got the long latent phase in which, since cervical cancer has got slow progression of about 10 to 20 years, hence screening plays an important role in detecting the early changes. Now, talking about screening for cervical cancer, screening of all sexually active women and timely treatment is done. It is effective as it can be detected earlier. Infection with HPV is the primary cause of cancer cervix and its precursor lesions. It is also related to anal, oropharyngeal and vulval cancers. It is a preventable cancer since vaccines are available for cervical cancer. Now, talking about HPV, which is a human papilloma virus, it belongs to papilloma viridae, which is a non-enveloped virus with double-stranded DNA genome. It also causes cutaneous and anogenital warts depending on the subtypes, which may further progress to carcinoma. There are 13 high-risk subtypes, out of which HPV 16 and 18 are the highest virulent types. Now, talking about the natural history of cancer cervix, when HPV infection occurs, 90% of it gets clear within 2 years on its own, while 60% it regresses within 2 to 3 years.
HPV, it gains access through microinvasion and infects the basal cells. Now, if it doesn't get cleared, CIN, which is cervical intraepithelial neoplasia, develops, and around 30 to 70% of high-grade lesions, they progress in 10 years, causing invasive cervical carcinoma. Now, when to suspect cervical cancer? The symptoms of CA cervix include abnormal vaginal bleeding in form of postcoital bleeding, intermenstrual bleeding, or postmenopausal bleeding. Patient may come with foul-smelling or vaginal discharge or chronic pelvic pain. Now, there are certain screening modalities available for detecting cervical cancer, which include cytology, in which conventional method like pap smear and liquid-based cytology is included. Visual inspection tests like VIA or villi. Co-testing like VIA villi stands for VIA stands for visual inspection with acetic acid, while villi stands for visual inspection with Lugol's iodine. Co-testing with HPV DNA and conventional method, while certain biomarkers like P16 staining, markers of proliferation, methylation markers, and high-risk HPV mRNA detection. These are also available. Now, talking about the conventional pap smear, it is conventional method for cervical screening. It prevents 70% of the potential cancers by detecting the pre-malignant lesions. It is taken using the IR spatula from the ectocervix and from cytobrush from the endocervix, after which the sample is smeared on slides and kept in fixative solution of 95% ethyl alcohol and kept in complex jar and then sent to the lab. These are the basic requirements needed for a pap smear. So here we can see how we are taking a pap smear from ectocervix through IR spatula. Now, moving on with HPV testing, it is a hybrid capture tube kit approved by FDA. The sample is collected similarly like pap smear with cervical swab taken from the transformation zone and placed in the transport medium. In this method, liquid-based medium is used to collect and preserve the cervical cytology cells and then transported to lab. It detects whether a person is infected with one or more of the 13 high-risk subtypes, and it is used as a screening test for age more than 30 years of age. Now, moving on with visual inspection after application of acetic acid. Here, around 3 to 5% of freshly prepared acetic acid is applied to the cervix, and cervix is examined after 1 minute. The main principle behind this is the acetic acid, it populates proteins of the abnormal cells, leading to the appearance of aceto-white areas. Since the abnormal cells, they are rich in proteins. So, VIA positive indicates shiny and cloudy white, more dense, thick and opaque lesions. So, here we can see the aceto-white areas around the cervix indicating positive VIA. Here also we can see in the first picture the aceto-white areas at around 10 o'clock and 12 o'clock position suggestive of VIA positive. Now, moving on with villi, which is visual inspection with Lugol's iodine. Here we apply mixture of Lugol's iodine and wait for few minutes. The normal cervical cells, they are rich in glycogen and they appear dark brown or black, while the abnormal ones, they don't take up iodine and appear yellow. So the positive test indicates well-defined bright yellow iodine non-uptake areas. Now, after confirming the screening test, if it comes VIA positive or villi positive, we move to colposcopy. It is a procedure of visualization of cervix and the lower genital tract under magnification. Its main aim is to identify the pre-invasive and invasive neoplastic lesions for the biopsy. It is gold standard for evaluation of patients with abnormal cervical cytology. Its main indications are abnormal pap smear, positive VIA or villi, suspicious looking cervix, or follow-up of any treated lesion. So here we can see that using a colposcope, we can see the cervix through speculum under magnification. Now, the Foxy recommendation for screening. So we start regular cervical screening at the age of 25 years among the general population. Screening with cytology is done every 3 years or by HPV DNA every 5 years in good resource settings, while via every 3 years in low resource settings. We stop screening at 65 years of age with adequate screening after 3 consecutive negative pap smear or 2 consecutive negative HPV DNAs. Moving on, after taking a routine pap smear, if the smear is abnormal or indicative of any low-grade or high-grade cervical lesions, we confirm it through colposcopic directed biopsy, which may suggest CIN1. In CIN1, we'll observe and repeat smear after 6 months, or if the biopsy is indicative of CIN2 or 3, we'll go up with a treatment like ablation in form of coagulation or cryotherapy or laser ablation, or we'll excise the lesion in form of LEAP or LEAPS. LEAP stands for large excision of excision procedure. Now moving on with HPV vaccination. So since cervical cancer is most preventable cancer, certain vaccines they are available against serotypes of HPV. We have 2 quadrivalent vaccines which are Gardasil and Sovavac available against HPV 11, 16 and 18. A bivalent vaccine named Cervarix against HPV 6, 16 and 18, and Gardasil 9 which is a nanovalent vaccine against 9 subtypes. So here we can see these are the vaccines available in market, out of which Cervavac is made in India by the Serum Institute of India, Pune. Moving on with HPV vaccination, who should be vaccinated? Girls and boys of 9 to 14 years of age are ideal age for vaccination, while the catch-up vaccination it can be given up till 26 years of age. Now, vaccination schedule for 9 to 14 years is 2 doses at 0 and 6 months, while for girls more than or equal to 15 years, we have 3 doses, 0, 2 and 6 months. Now, we have a WHO strategy towards eliminating cervical cancer which aims to set the world on the right track by 2030. It includes 90% of the eligible women, they should be vaccinated, while 70% of them, they should be screened, and 90% of the women diagnosed should be treated. So we have a recent campaign going on in our India, which is a HPV vaccine campaign. It was recently launched by our Prime Minister, Mr. Narendra Modi, to provide protection against cervical cancer by administering HPV vaccine. This program focuses on 14-year girls across all states and union territories. Here, a single dose of Gardasil is being administered under the drive, as many studies have also proved that single dose of vaccine is also effective. So this is how we can screen and prevent the cervical cancer. Now I would like to call Dr. Rohan to discuss the role of pathology in cervical cancer.
Thank you, Dr. Aastha. A very good morning to respected chairperson, all the dignitaries and everyone present in the hall. I would be discussing the role of pathology in screening of cervical cancer. As due to constraint of time, I will only be discussing the role of cervical cancer. So this is a pap smear. As discussed by Dr. Aastha, we get fixed lines, and at the bottom you can see after getting the fixed line, we stain the slides either by conventional method or by LBC. So in our institute, we get majority slides that are by pap staining, which is the conventional method due to the population that we cater. Then we proceed on to microscopy and the final report. These are the cells that are studied in a normal pap smear. Starting from the top, it is the superficial cell, the intermediate cell and the parabasal cells. Talking about briefly about the superficial cell, they have a pycnotic nucleus with a very small size nucleus. Coming to intermediate squamous cells, they have a nucleus of approximately 35 micrometer, and parabasal cells having 50 micrometer of nucleus. We also study the EC cells and lactobacilli, which is of the normal flora. The adequacy criteria for conventional PAP and liquid-based cytology is totally different. For conventional PAP, it is 8,000 to 12,000 cells, and for LBC, it is 5,000 cells. And LBC is recommended overall. Coming to diagnostic criteria, it is classified majorly into non-neoplastic and neoplastic. Except for neoplastic, we also cater to organisms such as Candida, which can be seen. The fungal hyphae and spores can be appreciated. Coming to trichomonas, a leaf-like pattern is identified. And coming to chlamydia, which has a typical clue cell which is characteristic of it. And there are other non-neoplastic causes such as inflammation, radiation, and intrauterine devices and atrophy. Coming to the neoplastic causes, they are broadly classified into ASCUS, that is atypical squamous cells of undetermined significance, ACSH, that is atypical squamous cells, HCIL cannot be ruled out, LCIL, that is low-grade squamous intraepithelial lesions, and HCIL, high-grade squamous intraepithelial lesion. Now, this is the normal cervix. Now, the HPV DNA first affects the basement membrane first. In SIN1, that is cervical intraepithelial neoplasia, it is classified as LCIL. We can see mild dysplasia, and you can see the lower one-third of the basement membrane is being affected. Coming to SIN2 and SIN3, they are broadly classified as HCIL. It can lead from moderate dysplasia, severe dysplasia to full-blown cancer. In SIN2, the two-thirds of the basement membrane is being affected, and when it goes to carcinoma, a full-blown HPV DNA affects the membrane. Talking about ASCUS, that is atypical squamous cells of undetermined significance. For our reference, the intermediate cell is the reference point. Here we can see that the cell size of that is the nucleus is large in size. Now we focus mainly on ASCUS for two reasons. We cannot classify ASCUS as reactive. These cells need a very close follow-up. So a repeat pap smear is advised after 6 months. Coming about to ACSH, that is atypical squamous, cannot rule out HCIL. In this, the cell size is again larger as compared to ASCUS. LCIL, we can see that the cells have a the larger size, and we can see multinucleation and binucleation. And following to HCIL, here you can see a very high NC ratio cell, and the reference point remains the intermediate cell. Lastly, coming to HPV screening solution, it is either mRNA based assay or DNA based assay. In our institute, we are doing HPV RT-PCR over here. Now I would like to call upon Dr. Sameer from the Department of ENT to talk about screening in head and neck cancer. Thank you.
Thank you, Dr. Rohan, for such a nice explanation. Good morning, everyone. Myself, Dr. Sameer Jain, President from Department of ENT and Head Neck Surgery, going to present the screening in head neck cancer. Coming to the oral cancer screening, oral cancer is one of the most common head and neck malignancies in India, largely due to the tobacco and alcohol use. Visual inspection of the oral cavity is the simplest and the most cost-effective method. It is recommended by WHO and it is recommended by WHO as the first-line screening tool, especially in the high-risk population, emphasizing that no sophisticated equipments are required, making it ideal for mass screening programs. A systematic approach is essential to avoid missing any lesions. Always follow a sequence to ensure the completeness. First, we will examine the lips, both the upper and the lower, followed by the buccal mucosa, both right and the left, followed by labial mucosa, gingiva, both hard and the soft palate, floor of mouth, coming to the oropharynx, then finally the tongue. We use good lighting, gauze and a tongue depressor for the proper visualization. We pay special attention to the high risk site, especially the lateral border of the tongue and the floor of mouth. Not all abnormal lesions in the oral cavity need biopsy. Some lesions may result from chronic irritation. It can occur in both tobacco and non-tobacco users. In non-tobacco users, it occurs due to the chronic irritation due to ill-fitting dentures, half-broken tooth, or poor oral hygiene. In India, especially in the rural areas, people have poor oral hygiene, which predisposes them to infection. There are some red flag signs which will mandate the biopsy. As we can see on the screen, on the first picture there is a whitish patch which is called as a leukoplakic patch. Leukoplakic patch are pre-malignant, but not all are malignant. Secondly, there can be a reddish patch called as the erythroplakia. Erythroplakia has a higher malignant potential than the leukoplakia. It is about 10 to 20 times more malignant than leukoplakia. Then there can be mixed erythroleukoplakic patch, mucosal ulceration not healing for more than 2 to 3 weeks, or any hard indurations. Then other concerning findings are fixed mucosal lesions, unexplained mucosal bleeding, or asymmetry in the tongue, palate, or the floor of mouth. In the neck, if there is unexplained lymphadenopathy, which is hard, non-tender, more than 1 centimeter and persistent for more than 3 weeks, we should find the primary cause. As a thumb rule, in India, if a male patient more than 30 to 40 years of age is presenting to an OPD with a history of smoking and has unexplained supraclavicular cervical lymphadenopathy, we should suspect malignancy. Oral cavity screening has been significantly proven to detect the lesion early and improve the outcome. The Kerala model, a landmark Indian study showing the effectiveness of the screening, a community-based randomized controlled trial performed by the nurse where they performed visual oral screening in Trivandrum, India. It is conducted in the high-risk population of tobacco and alcohol users. It was conducted over 9 years with 3 screening rounds. A total of over 1.3 lakh individuals were screened, and the result of the study was 22% reduction in the mortality and a better 5-year survival in screen-detected cancer cases versus the symptomatic cancers. This proves that community-level screening works in India. Now coming to the M-Sheath, which is a project in the innovative mobile health initiative designed to improve early detection of the oral and head and neck cancers in a community settings. It combines the mobile technology with trained health workers and telemedicine. In India, most patients present with advanced stages, mainly due to the rural population, have limited access to specialists. So this is a tech-assisted screening approach in which first we identify the high-risk individuals, followed by the data entry into the mobile app, which is then followed by the visual oral examination with good torch tongue depressor by a health professional, followed by image capture, then teleconsultation. Then we divide the risk into a low risk and high risk. The low risk we do a follow-up, and for the high risk we do a refer to a higher center where we do a biopsy, and then we do a regular follow-up and tracking. So in the end, I would like to say, for oral cancer screening, it will need only a 5 minutes to screen the oral cavity, and we require only a tongue depressor, a torch, and a few pieces of gauze to screen the oral cavity. Now, I would like to call Dr. Lalit Mohan sir to carry this conversation forward.
So, good morning, Emeritus Chairperson sir, respected teachers, my dear friends and students. I think most of the things have been covered. I will be just talking about what we are doing and what we intend to do in future. So at our hospital we are doing opportunistic cancer screening, very effectively done in gynae department. They are doing pap smear of all the women attending the OPD. Of course, in our cancer center also, like the relatives of patients, we are offering them screening whenever they agree to that. Population-based screening yet is not feasible, but with the MOU with the government of Rajasthan, with the availability of the mobile screening, when we are moving out of Jaipur also, and we have done 2-3 camps out of Jaipur also after test trial in the Jaipur city. The mobile screening initiative now is almost 4 months old, and we have covered more than 18 camps, and a high-end breast mammography machine is available. In real time, the data transmission from the mobile van to the radiology department is available. If we are doing a camp on weekdays, we get the report on same day before the camp is winding up. If it is camp is being done on Sunday, then probably next day we get the report of the mammography report. In addition to mammography, we are doing pap smear and gynecological examination, ENT checkup, and X-ray is also available in the mobile screening van. These are few snapshots of the mobile screening van, and we are quite excited about that. And we had discussed with the government of Rajasthan. They have allotted us Tonk as district to start working in a block of Tonk as well as in Bhilwada Gulabpur area. Two things they have done. So till date we have done screening of registration of close to 1500. 400 plus people have been screened with various tests, and out of them we were able to pick up 13 cancer cases. 2 breast images we have seen, and majority of them were head neck cancer cases. We are working in fact for many decades about the cancer prevention. We are going to different schools since more than a decade, trying to educate the children about tobacco hazards and trying to motivate them. Personally tried 6 years back in Bhilwada in one CHC area to have one like cervical cancer screening project, HPV pap smear. We started testing, but we could not succeed there. We had done various awareness activities, tobacco campaign in various factory workers, companies, awareness talks at various levels, and happy to share that after joining Mahatma Gandhi Hospital over last 3 years, we have representation of Shri Ram Cancer Center at the annual meeting of American Society of Preventive Oncology, where I was given the travel grant also $1,500, and last year we had representation in the European Society of Preventive Oncology also, where 2 papers, one was about the tobacco awareness and cessation oral screening project which we have done in Bhilwada in Bhavani Mandi. So more than 300 patients data were there in that portion, and other was about the cervical cancer awareness project. So both these papers were there. We have seen about the rapid rise in the cancer incidence, and we can see these 3-4 major cancers in the lip and oral cavity, almost 70% plus projection by the WHO in next 25 years. And if we see the breast cancer projection of more than 65% number, as well as the mortality, both is likely to increase, and the cervical cancer also. So there is a huge gap between the incidence and mortality, and this is high time that we all should work together. Even the colorectal also is rapidly rising, GI cancer is rapidly rising. So in India we are witnessing a tsunami in the cancer burden. Lifestyle is rapidly changing, aging is advancing. So both these factors leads to high number of cancer cases. The mortality is high in developing countries. So we cannot afford to have more and more of advanced cancer cases. So we need to work at prevention as well as early detection level. So the challenges are illiteracy, infrastructure, low priority of cancer, and there are various gaps. Primary, secondary prevention has been done by Dr. Parul very well, and we need to focus from the treatment centric to the prevention as well as early detection centric. These are 3 common cancers we have discussed. A few words about the good cancer screening tests. Nowadays various blood-based tests are available, which are pretty expensive tests, more than $1,000 test, and the specificity sensitivity is low. So we need to have the benefit and harms of any screening test done. Ideal cancer screening test should be affordable to most of the people, and the test should be such which can be implemented in the remote rural areas of Rajasthan and to like poor person as well. It should not be highly expensive. The fight against cancer will be by prevention as well as early detection, and we all need to unite together, because it is not only the responsibility of government to bring down the cancer awareness and other programs successfully. It becomes our responsibility. Our means each individual is responsible to educate the layperson, common man, and provide them early detection and education, prevention and screening. At the end, if you see this picture, here the zebra is like a normal person or a patient, and this is the cancer or non-communicable disease is like a lion. So what is happening? The zebra will be caught by this car. The zebra cannot run faster than this car. What does the motorcycle indicate? If we can provide the modern motorcycle, which is in the form of healthcare workers, infrastructure, providing them early detection, screening, then probably this zebra can run faster than this coin, and we can save millions of lives. So with this I end up, and I thank Emeritus Chairperson sir, all my faculty colleagues. I thank Dr. Sharma and his team for giving us an opportunity for cancer screening. Thank you.